The first test I'll be doing to assess for anterior shoulder instability is the anterior jaw test. So with the patient in supine, I'll bring him into about 80 degrees of abduction, slight flexion, and external rotation. So my mobilizing hand is going to be under his axilla area, and then my stabilizing hand will be placed over the spine of the scapula and the coracoid. I'm going to then apply an anterior force with my right hand just as so, and a positive test result would be a click, clunk, or reproducing the patient's apprehension or symptoms. The test I'm going to be doing on Bruce is the apprehension, relocation, and surprise test. So first starting with the apprehension, what I'm going to do is bring him to 90 degrees of abduction, and then I'm going to go ahead and externally rotate until he feels pain. So this is very painful for him right here, so that's a positive apprehension. So I'm going to bring him out of the position, and then starting again, I'm going to apply a posterior stabilization this time, and when I relocate, if he can get farther and less painful, that's a positive test. And to go ahead and surprise him, I would just lift up my hand, but clinically that's not really done because it is very painful for the patient, but yes, the loaded shift. So what I'm going to do is I'm going to come on both sides of the acromion, and I'm going to stabilize here, and then I'm going to palpate for his humerus, and then I'm going to first shift it anterior, and then I can also go posterior. So with both of those, a positive test would be reproducing his pain, or excessive movement with a click or clunk indicating some instability either anteriorly or posteriorly. So the jerk test is done for suspected posterior instability. So I'm going to bring the patient's arm into 90 degrees of flexion and stabilize the scapula area, and then I'm going to internally rotate his arm and apply an axial load by pushing posteriorly and then bringing his arm into horizontal adduction. So a positive result would be a clunk or reproduction of pain because this would be the head of the humerus subluxing off the glenoid. So the posterior apprehension test will be done to assess for posterior instability. So with the patient in supine, I bring his arm into 90 degrees in the plane of the scapula, and I'm going to internally rotate and horizontally adduct while applying a axial load posteriorly through the humerus. So a positive test result would be reproducing the patient's apprehension or a clunk due to the humerus subluxing posteriorly off the glenoid. So the next test to assess for posterior shoulder instability is the posterior jaw test. So with the patient in supine, I'm going to place my mobilizing hand under his axilla inside there, and my stabilizing hand is going to be placed over the coracoid and spine of the scapula. I'm going to use my right hand to provide a posterior force on the head of the humerus, just as so, and a positive result would be a clunk, click, or reproducing the patient's symptoms of pain. The sulcus test is done to assess for multidirectional shoulder instability. So I'm going to find the acromion and place my hand over the subacromial space, just resting there. I'm going to palpate for his distal humerus and then provide a downward traction. So a positive result would be the presentation of a gap or feeling a loss of pressure upon the traction. The first test I'll be demonstrating to assess for shoulder impingement is the Hawkins-Kennedy test. So I'm going to place the patient's arm into 90 degrees of flexion and then forcefully push him into internal rotation. So a positive test result would be a reproduction of his pain. And clinically, this test may yield a painful response of many patients with shoulder complaints, so it might not be done as often. Another test to assess for shoulder impingement is the Zaslav's test. So I'm going to bring the patient's arm into 90 degrees of abduction and 80 degrees of external rotation. And from this position, I'm going to resist the patient in internal rotation and assess for any weakness or a reproduction of his pain. So then, in the same position, I'm now going to resist him in external rotation and assess for any pain or weakness. So if the patient is weaker with internal rotation versus external rotation, this this will indicate a source of intra-articular derangement or a labral tear, whereas if he's weaker with resisted external rotation, this means a possible rotator cuff issue or subacromial impingement. The Neers test is another test done to assess for shoulder impingement. So I'm going to bring the patient's arm into full 180 degrees of abduction with maximal internal rotation, and I'm going to look for any reproduction of pain or pinching in the subacromial region, which would be a positive test result. So this test can be repeated with max external rotation into 100 degrees of abduction, and if the patient's complaints are reproduced at the AC joint with this motion, this would indicate possible AC joint arthrology. The supine impingement test is also done to assess for shoulder impingement, so I'm going to bring the patient's arm into full abduction with maximum external rotation and slight adduction. And then from this patient, I'm going to bring his arm into max internal rotation, and if going into the internal rotation here reproduces his complaints of pain, this would indicate a positive test result. The posterior internal impingement test is not usually used as often clinically to assess for impingements, as it usually is done on overhead athletes, but with the patient in supine, I'm going to bring his arm into about 100 degrees of abduction and into slight extension, and then I'm going to maximally externally rotate his arm, and a positive test result would be reproducing the patient's posterior pinch or pain in that area. The O'Brien's test is done to assess for labral tears, so I'm going to have the patient bring his arm into 90 degrees of flexion, maximum internal rotation, and horizontal adduction. I'm going to resist him with any further shoulder flexion with his palm down, and if that reproduces his pain, that would be a positive result. But then as I have him flip his palm up and apply the same resistance, if this is less painful, that would indicate a positive result, with his thumb up being less painful. So the biceps load tests are another test done to assess for labral tears. There's 1 and 2. So biceps load 1 is done with the arm in 90 degrees of abduction. And with his arm supinated, I'm going to resist his biceps contraction. And a positive result would be reproducing his shoulder pain with the resistance. And then biceps load 2 is a more sensitive test and is done in 120 degrees of abduction. And with his arm in supination, I again resist his biceps contraction. And a positive test result would be reproducing his shoulder pain. The anterior slide test to assess for labral tears is done by having the patient place his hand on his hip with his thumb facing backwards. So I'm going to stabilize with my left hand on the clavicle and scapula, and then I'll apply a superior and anterior force through his elbow with my right hand. So a positive test result would be a click, pop, or reproduction of his pain with this motion. The Clunk test is another test to assess for labral tears or even possible anterior instability of the shoulder. So I'm going to make a fist with my hand and place it under the posterior aspect of his shoulder. I'm then bringing his arm into abduction and external rotation and trying to drop his arm over my fist. So a positive result would be a clunk or reproducing his complaints of pain. Another test to assess for a labral tear in the shoulder is the labral crank test. So I'm going to bring his arm into about 120 degrees of abduction, and I'm going to axial load through his humerus as I bring his arm into internal and external rotation, just like this. And a positive test result would be a reproduction of his complaints, a click, or a pop. This next test for assessing for labral tears is called the resisted external rotation supination test. So I'm going to place the patient's arm into 90 degrees of shoulder abduction, 70 degrees of shoulder flexion, and maintain a neutral position at his forearm. Then I'm going to provide resistance to his supination, and I'm going to move him into external rotation while providing this resistance, as done so there. And a positive test finding would be a reproduction of his complaints, a click, or a pop. Alright, so the first test And the series of AC joint tests is the crossover test, which will be indicated to do if the patient does have some pain during about 170 to 180 degrees of abduction, so indicating possible AC joint involvement. So what I'm going to do is I'm going to bring him into, starting at about 90 degrees of flexion, I'm going to palpate his AC joint region, and I'm just going to bring him into full horizontal adduction. And if that reproduces his pain, that would be a positive result indicating probable AC joint involvement if it's in that area. This next test I'm going to be doing is the AC joint shear test. So it's like a cupping motion. So what I'm going to be doing is coming to the posterior delt by the spine of the scapula, and then again taking one hand and placing it at the mid-clavicle and anterior delt. I'll then compress with my hands here and create shear. So a positive finding would be a reproduction of the patient's anterior complaints of pain. The final test to test for any AC joint pathology or involvement is going to be the Paxino sign. So I'm going to put my thumb on the posterior part of the acromion right here, and my middle finger and index finger is going to come to the mid-clavicle, and I'm just kind of pinch together here, looking to reproduce any of his symptoms, which would indicate some AC joint involvement. Positive result. The external rotation lag sign test. So we're going to bring the patient's arm up to 90 degrees of abduction, external rotation here, and then I'm going to tell him, I'm going to let go, okay? And he can hold that there, so that's negative. But say his arm is starting to lag into internal rotation and falling down, that would be a positive test indicating some involvement of the supraspinatus or infraspinatus muscles, and yes, positive finding. So the next test we're going to be doing for the subscapularis muscle is the internal rotation lag sign. So I'm going to start by bringing the patient's arm behind his back like this, and I'm going to lift it up, and I'm going to ask the patient, can you hold this here? And he can, but say it was to fall and he wasn't able to hold it and his hand began to touch his back, that would be a positive test result indicating subscapularis involvement. So this next test that we're going to be doing is called the Hornblower sign test, specifically assessing the teres minor muscle of the rotator cuff. So I'm going to start by bringing his arm into 90 degrees of the scapular plane and external rotation, and here I'm going to have him resist external rotation here. Okay, so he's able to do that, so that's negative. But if he wasn't able to resist me and his arm began to drop down and he wasn't able to hold it, that would be a positive test result indicating teres minor involvement. So this next test assessing rotator cuff involvement, specifically the subscapularis muscle, is called the belly press test. So what I'm going to do is I'm just going to put my hand over his belly and have him meet my hand there, and I want him to press down into his belly as so. Alright, which is great here, but if it was a positive test result, he would either flex his wrist to get the motion, flex his wrist, or he would extend his shoulder back, which are both positive test results indicating involvement of the subscap. The drop arm test. So what I'm going to do is stabilize here at his spine or acromion area so he can't substitute by his scapula. I'm going to passively abduct his arm into 90 degrees, and I'm going to have my lift up, and then I'm going to ask him to slowly lower down his arm. So that is a normal finding of a test result, but say if I were to bring him back up here and I let go and he falls like that, can't control it, or when he's up here and he instantly falls down, that would be a positive finding. So this last test assessing the infraspinatus muscle of the rotator cuff is called the dropping sign. So I'm going to passively bring him into about 45 degrees of external rotation right here, and I'm going to have him resist me. Alright, which is good, but if he can't resist me, that would be a positive finding indicating infraspinatus involvement. The Speeds test is done for suspected bicipital tendon pathology, so I'm going to bring the patient's arm into 90 degrees of flexion, And at the wrist, I'm going to resist flexion with the palm up. So if this reproduces the patient's pain, that would be a positive finding. So then if I turn his palm down and repeat the test, if this is less painful and feels better than having the palm up, that would indicate a positive finding. So I can also be more sensitive with this test by bringing his arm into 90 degrees of flexion with slight elbow flexion, and I'm going to resist both shoulder and elbow flexion. So if this is painful, that would be a positive test finding as well. The Jurgensen's test assesses the long head of the biceps for subluxation, as well as looking at the integrity of the transverse ligament. So I palpate the long head of the biceps tendon and place my fingers here. So with the patient starting in forearm pronation, I'm going to then have the patient turn his palm up and rotate his arm out as I resist this. So a positive result would be a popping at the tendon or subluxing of the biceps. The first joint mobilization I'm going to be doing on my patient is a posterior glide at the glenohumeral joint for improving flexion and managing pain. I start by bringing his arm into the open pack position of 55 degrees of abduction and 30 degrees of horizontal adduction. I'll then use my mobilizing hand to apply a posterior force at the head of his humerus. My force is going to be going perpendicular to his arm. And first, for a grade 1 MOB, for pain control, this will use a small amplitude at the beginning of range. So next I can move into a grade 2 with larger amplitudes within the range. Grade 3 will consist of larger amplitude at the limit. And finally, moving on to a grade 4 will be a small amplitude into the resistance. The next joint mobilization technique I will be demonstrating is an inferior glide at the glenohumeral joint. Again, I'll start with the patient's arm in the open pack position. I'll then apply an inferior force at the head of the humerus. So I'm going to be progressing from a grade 1 using a small amplitude at the beginning of the range through a grade 2 and 3, and finally up to a grade 4 at the end range into resistance using small amplitudes. And this glide is to gain abduction. The next mobilization I'll be doing is a lateral glide at the glenohumeral joint. So I'm going to start again in the resting position in the shoulder of 55 degrees of abduction and 30 degrees of horizontal adduction. I'll be placing my hand under his axilla and using my body to rotate and help move the force laterally. So this is for pain control and general mobility using that lateral glide. And I'm moving the proximal humerus laterally as I mentioned. Right here is a grade 4 as I'm going into the resistance at the end range with those small amplitudes. To increase general mobility in the quadrant position of the shoulder, I can do a grade 2 row the boat mobilization technique. So I bring the patient's shoulder into flexion and the elbow into about 90 degrees of flexion, and I do this rhythmic rocking back and forth. It's a repetitive motion, and this is a grade 2 quadrant mobilization. The last joint mobilization I'll be doing is a quadrant grade 3 flop the fish. So I'm going to bring the patient's arm into abduction and external rotation. I'm going to make sure my arms are inwards towards my body and grasp the patient's arm near his distal wrist. Then I'll begin a rhythmic motion using my wrist mainly to flop the fish, as shown here. And this is really good for increasing generalized mobility as well as with controlling pain for post sessions.